I'm going to talk about, which is the surgeon's perspective on pediatric melanoma. And you've heard already a lot about how much is changing, and we think that a great deal has changed and continues to change, and I say the future is now. Melanoma treatment is changing rapidly. It's changing for adults first because that's where we test the newest ideas. There are more of them, more adults with melanoma, and we usually start with them first. So you've heard a little bit about some of these new technologies for diagnosis of melanoma and about communicating how certain we are that this really is a melanoma. That's what Dr. Messina was just talking about. I'm going to talk about looking in those lymph nodes, excuse me, and how we've changed how we deal with that. And then lastly, about improved treatments to prevent the melanoma recurrence or treat it once it does come back. Now, absolutely the standard treatment for anything that we think might even possibly be melanoma for as many centuries as we've known what melanoma was, is to remove the lump, get rid of it. And I can't emphasize another point enough. Dr. Messina didn't really talk about it that much, but the diagnosis is a dynamic process. Sometimes that biopsy, she showed several different things, especially with children. The dermatologist likes to do the smallest possible biopsy. It's a little kid. We don't want to do a big thing. We don't want them to have a big scar. It's probably nothing. They give a very tiny biopsy. The pathologist is sweating and trying to figure out what the heck this is. I can't even tell. I don't see any of the standard clues. We go back and remove the whole thing. It's like a jigsaw puzzle where you kept one piece from the person putting it together. Suddenly you put that last piece in and you say, oh, I thought this was the Eiffel Tower. It's something totally different. And the importance of, yes, the biopsy may show something, but let's take out the whole thing and look at it. Even benign things, as we heard about from one question, can come back. Even benign lesions today can keep getting hit by ultraviolet radiation and turn into something bad. So we always start with taking it out. If we know it's melanoma, we measure around it and take more of it out so we're sure that we get all of the roots, and we make sure the pathologist sees that we have indeed gotten it out completely. If we think it has a risk of having spread to the lymph nodes, but the lymph nodes seem normal, we've learned that under the microscope we can find melanoma cells in a significant percentage of cases that feel and look and seem totally normal. And we do what's called a sentinel lymph node biopsy. That involves injecting one or usually two types of tracer. This is our blue dye. You can see we've turned the edge of this melanoma blue so that that blue gets into the lymph channel and is carried to the lymph nodes and turns it blue so we can see it. We also usually use a radioactive tracer so we can tell where the lymph node is even without going through the skin. It allows us to make a very small incision, and what do you know, there's that blue channel going right into a small little lymph node about the size of a small lima bean. And right there, right at that corner of the lymph node, is the place that is most likely to have any cancer cells if the cancer has moved from the primary area through the lymphatic channels to the lymph node. And this is what that lymph node looks when we take it out. These marks here, we've actually painted the lymph node, inked it, so that the pathologist can tell where in that lymph node we saw that dye and make sure they look at that part. They look at the whole thing, but we want to make sure they look at that area where we've put the ink. And sure enough, often right under that spot, they can detect tiny areas of melanoma. I don't know, maybe Dr. Massey can say roughly how many cancer cells that would be, 100 maybe, 50?
Yeah.
We've certainly seen cases where there's even just only 1 or 2 or 3 show up. So this is a small deposit, but it's not by any means the smallest one that we could ever find in a lymph node. This is here, now you see we're down to just a couple, 4 or 5 cancer cells showing up in that lymph node. And it is very, very, very sensitive. What's it mean? We did one of the studies of what does sentinel lymph node biopsy mean specifically in children, one of the largest studies of its kind. And here's what we found out. And I want to point out that for this particular study, and for much of what I'm talking about, these were cases that we would have categorized as giving them that number 5. It isn't just a questionable, let's do this just to be safe. This is, uh-oh, I've run all the tests, I've put everything together. Maybe at first it was a question mark on the little biopsy, but now that we've got all the information, this is melanoma. If we say it's melanoma and we say it's in the lymph nodes or not, what does that mean? It's a different discussion. If we're not sure and we take out something in the lymph node, how does that help? That's a little bit of a different discussion. So what did we learn? Higher rate of positive lymph nodes, almost 30% in pediatric melanoma compared with adults, where that number would be somewhere between 12 to 16%. So about twice as likely to have a positive lymph node for a child and for an adult. Could be because they have really strong lymphatic system, the current is quick, it brings things quickly. It could be because their lymph nodes are better filters and capture the cancer cell before it gets loose and we can see it. Could be a lot of different things, could be a different biology, but this is a pretty consistent finding. Other studies have seen the same thing. The thicker the tumor, the more likely to have a sentinel lymph node that's positive. Brenda asked the question or mentioned a doctor who said, oh, your melanoma is 7 millimeters thick, it's got to be in the lymph node. I know one of my compatriots at Sloan Kettering in New York, who is also the head melanoma surgeon there, he always uses the rule of 10. He says, I multiply the thickness by 10, and that gives me an estimate of the likelihood that I'll find a positive node. So if your melanoma is 2.9 millimeters thick, you would predict that you had a 29% chance of having a positive node if you used that 10 times rule. It's not a bad rule, but it's not an absolute either. In fact, it doesn't even start to work till you get to about 0.8, because at 0.8, now, yeah, you have close to a 6, 7, 8% chance. Once you get to 3 or 4, it starts to fall off, because from 4 millimeters and above, including 7 millimeters, 8, 14, kind of plateaus out. There's about a 30 or 40% chance of a positive node. It doesn't go up to 100 if you get 10 millimeters. So a 7 is not 70. It rises, levels off. The thicker the melanoma doesn't always mean the higher the chance. It's like if it got this big and it hasn't spread, maybe it never figured out how to spread. Maybe we can get rid of it and it will never know. Or maybe it just doesn't go to lymph nodes, it shows up somewhere else. But in general, this statement is true. The Breslo's thickness is predictive. Thicker tumors are more likely to have positive nodes, just like in adults, but it's not an absolute. And just like in grown-ups, if we find that the melanoma is in the lymph nodes, there's more chance that we're going to find something else, somewhere else, someday in the future. Not always in adults, not always in kids. Sometimes getting that cancer out of the lymph node takes care of it completely. Sometimes getting that cancer in the lymph node, there's some other cells and we can get rid of it with additional treatment. But in general, the more we find of your cancer in the lymph nodes, the worse it is. And here's an interesting thing. And again, we've seen this over and over in our studies, but so have many other people around the world who've studied pediatric melanoma. The stage and the outcome are not exactly the same as in adults. Despite the fact that we have about twice as many positive nodes in a kid than in an adult, and despite the fact that having it in a positive lymph node is not as good as not having it in a positive lymph node, you would think then that it should be twice as bad to have pediatric melanoma, and it's not. It's actually better. Is it because children have stronger immune systems? Is it because those lymph nodes were super good at filtering things out, didn't let anything go by? A lot of possibilities. Is it because there's a different biology? The genes aren't as badly damaged by DNA damaging ultraviolet radiation? We don't know. But this is a consistent observation. Overall, at every stage, children do a little bit better, sometimes a lot better than grown-ups. And younger children appear to do even better to some degree. Now, this is partly because there are those different categories of melanomas in different age groups. And so this is a generalization, but it is something that tends to hold true. And here is something that not a lot of studies have recognized, often because the studies only go on for a year or two. But we think it's extremely important that recurrences, and yes, even deaths, are seen beyond 5 years after the initial diagnosis. So we like to watch people for years and years, and if you were 10 and now you're 15, you're not completely out of the woods. You might have gone through puberty in between. We haven't seen that correlates with this reoccurrence, but we have seen that this isn't just something you can say, oh, that was last year, I don't have to worry about this anymore. We want to watch people for years and keep checking on them. Now, a big change has been, what do we do if the lymph nodes are positive? This is really a big, huge change. We used to do surgery on every single person who had a positive sentinel node. We would go back a few weeks later and remove all of the lymph nodes. We would do that. There was not literally a week that went by in this hospital that we didn't do at least one, if not several different lymph node dissection surgeries a week. Okay? It's been about 2 years since the last time we did one, just because we saw something in the sentinel node. It used to be 100%, now it's almost 0%. The sentinel node biopsy is very useful for determining if it's spread to the lymph nodes, and just removing that sentinel lymph node has relatively few side effects. Not none, but few. But removing all the lymph nodes caused more problems, and most of the time we didn't find anything, and now we know it just doesn't help very much. You see here that the outcome exactly the same. Can be red, blue, colorblind, it doesn't matter. It didn't change anything in terms of outcome to remove the lymph nodes. Okay, if they're watched carefully, and this is again, not because if it's an enlarged lymph node, but just microscopic, we don't have to remove all the lymph nodes unless it becomes enlarged. Other treatments are also changing rapidly. We used interferon for decades, and now interferon has almost entirely been replaced. About 2 years ago, we started to switch over from interferon to the newer drugs that are better than interferon at stimulating the immune system. Interferon, ipilimumab is a little bit better than interferon, not a lot, and also has side effects. But this one, the anti-PD-1 antibodies, definitely have fewer side effects than interferon, definitely better than IPI in adults, but we haven't got a lot of experience with this in children, in part because some of the side effects, when they do occur, can be very long term, can occur later on in ways that we don't want to deal with. What's happened, what's changed, all these and many others are studies that have been looking at what can we do to prevent the melanoma from coming back. That's called adjuvant therapy, giving drugs to people after surgery to try to prevent the cancer from coming back, to, as I say, kick the can down the road. And the progress that's been made here is pretty impressive. Ipilimumab is really is better than doing nothing, and about the same as giving interferon. It helps somewhat, but the side effects are high. You get a lot of treatment, and it actually is a dangerous treatment for some people. This is the anti-PD-1 showing it's better than IPI, but this also has some long-term problems that could be big issues for younger patients. So we have tended to use BRAF inhibitors in children when we need to try to delay the reoccurrence. And you see, this is, if we do surgery, give a BRAF inhibitor combination, dabrafenib, trametinib, or a placebo, the patients who got the BRAF inhibitor for just 1 year were still better off after 2 years and 3 years. And as scientists, we calculate the p-value. The more zeros, the better. This is the most zeros we've ever seen in any cancer trial ever. So doesn't mean it's the best ever, but it is statistically one of the strongest observations we've ever made. And it even seems to make survival better, but it is still early. We're going to need more years of study to be sure. So even if the melanoma comes back, we use these same drugs, immune therapy and targeted therapy against the BRAF. Is it chemotherapy? Depends what your definition of chemotherapy is. Any chemical that is used for treatment is technically chemotherapy. When we actually talk to an infectious disease specialist, they say, of course I use chemotherapy. I use penicillin, I use amoxicillin, I use chemicals all the time to treat infections. Well, that's not what I'm talking about. And dabrafenib, trametinib, ipilimumab, these are not the chemotherapies that people are usually thinking about. The cytotoxic drugs that cause your hair to fall out, that are given to people with leukemia and breast cancer, and some people with melanoma. But these drugs are a different kind of chemical altogether. Targeted treatments, immune treatments, they're much more effective than standard cytotoxic chemotherapy in adults, and we think so in children as well. And it's changing literally all the time. So the future is still out there. But we've talked about this a lot. Whether the melanoma is BRAF mutant or wild type, that's what we call it if it doesn't have a mutation, is a big fork in the road. It changes the options of what we might do if the cancer is to come back. It changes the options of what we might do to prevent the cancer from coming back. But it probably, in and of itself, it doesn't say your cancer is better or worse. Is it better to have more choices? Yes. Is it worse because you had this mutation? Not necessarily. And one thing is very much for sure, that it is not just if I have BRAF, I go to the right, and if I don't have a BRAF, I have to go to the left. It is a very, very complicated roadmap, and many people have a BRAF mutation and never get a drug that targets that BRAF mutation because they didn't need it. So it's a really complicated thing, but it's important to know for later stages, and we test every stage 3 positive nodes or stage 4 melanoma for the BRAF test. So the future ain't what it used to be. That's what Yogi Berra said, and I think that's still true today, and probably will be in the future. And we also want to remind ourselves why we're here. Moffitt's motto is "Your courage inspires ours," and we absolutely are reminded of that every time we see some of our children. And I always say, never underestimate the courage of a kid. A few years ago, the world's melanoma research meeting was in Brisbane, Australia, and just down the road from my hotel, I saw this boat and went over to look at it and see what it was. And sure enough, it was the boat that a 16-year-old girl from Australia sailed around the world in all by herself. The boat was 33.5 feet long and took her, see how many months, and she sailed around the world all by herself. So we are always excited about the courage of our warriors, our children with melanoma, and this is the annual Melanoma Summit that takes place every year. If you want some more information about that, we can talk about it. I also promised to mention this Pediatric Melanoma Registry that we're working with AIMatMelanoma. You've heard all about that already. We're working with 9 other sites, including Pittsburgh, St. Jude's, MD Anderson. We've already been collecting our melanoma patient data for years for both children and adults, and we're delighted to share this with others and build our numbers to get more scientific observations and make more discoveries that one team alone would never have the power to discover. So we agree with AIMatMelanoma. The ultimate goal is to cure pediatric melanoma, but to cure something, most of the time you've got to understand it. And we still have a lot of questions about pediatric melanoma that we need to answer. So we greatly appreciate everybody being here today, and I'm happy to take a few questions.